Women aren't comfortable sitting down with their friends and saying, hey, you know how we all sit and talk about the best products for the wrinkles around our eyes? How's everyone dealing with their aging vaginas, right? It's not something that comes up in the gym over brunch. We're not all sitting here talking about it. We're not educated about it, right?
Yeah. Well, and one of the things too, I would say there is like for so many women, they kind of just shove this away as normal. This is a normal part of life. It's a normal part of aging. It's normal by definition because so more women experience it than not. So that makes it normal. It does not mean we have to live with it.
Welcome to Modern Menopause by Parlor Games. I'm your co-host Morven, and this is Dr. Robyn, an all-round expert on everything from hormones, saliva testing, and so much more. She is our consulting physician over here at Parlor Games, and she's going to be co-hosting today as we talk about a very interesting topic, vagina aging. That's the topic title I'm going to go with today, Dr. Robyn, is your vagina really aging? So this is kind of a fun one because it's something that we don't think about very often, is that our vaginas and our vulvas are actually changing. So before we got on today, I was talking about, the fun wrinkles around my eyes. That stuff's happening all over your body, including on your vulva and your vagina. And a lot of women start to experience changes. And for a lot of women, they think, this will just go away. This is a normal part of aging. It's not something I need to worry about. Maybe I'm getting itchier, drier, a little bit uncomfortable. But actually, that's not really true, right? And so I'd love it today if we could talk a little bit more about vagina aging. What's happening physically to your vagina, to your vulva, to the muscles, to the skin, to the clitoris, to the labia that women are experiencing and maybe don't really have a term for, although hopefully after listening, the term will be vagina aging.
Yeah. I like that term. I think it works well.
Yeah.
And this is something, honestly, so many women experience, but I think a lot of women don't talk about it. It's a taboo subject, maybe, and maybe they think that they're alone, and so they don't know their friends are experiencing it or don't want to bring it up with their doctor, and maybe their doctor doesn't bring it up, but the changes that are happening can be really uncomfortable and significantly impact somebody's quality of life. So
right.
Yeah. What we see there is just like you mentioned, we see the wrinkles on the face associated with thinning skin, loss of tissue, loss of elasticity. We can see the same thing in the vulvar tissues and changes to the vagina itself. And when that happens, women might experience dryness or itching, or pain with sex, discomfort with wearing pants, increased UTIs, like you mentioned. There's a lot of concerns that equate to these changes that we're having, and ultimately the changes really come down to loss of estrogen, and that doesn't equate to whole body estrogens even. It's just loss of estrogen in those tissues, in that area. So a woman doesn't have to be experiencing a lot of other concerns like hot flashes, night sweats, the typical things that we associate with perimenopause and menopause to be having these concerns. And it can be addressed actually without, without using, whole body estrogens as well.
Right. Well, and because I think about this as there's a couple different clusters of types of changes, right? So I would say that there's changes, and we hear from a lot of women about this, right? This is one of the common things I would say in our Sexy Sassy Sisterhood, in our private Facebook group. We get women who kind of feel comfortable enough or work up the courage to be like, hey, has anyone else experienced insert, the issue here? And that's often things like, hey, my labia are shrinking. Right. My clitoris is shrinking. Color changes is a big one. And women are like, hey, I've noticed, is something wrong? There's a lot of discoloration. And so some of these changes are purely cosmetic, right? Labial color changes, it's not affecting you in terms of, hey, this isn't going to hurt if you have sex, if your labia is changing color. But obviously some of these changes are going to cause issues, right? So increased wrinkles, I know we talked about with the increased chance of UTIs. There's also this whole other group that we haven't touched on, which is internal changes. Things internally happening with the muscles or the kind of inner structure of the vagina rather than the vulva as we age. And so I'm wondering if you can speak to kind of these different groups of changes, right? The cosmetic changes people still don't like, right? They're like, hey, I've had loss of labia volume and I don't like it. Or maybe things that do have an effect, things like increased, I don't know what you call it, wrinkles or like looseness in the tissues, maybe shrinking clitoris, causing some issues for
Right.
women having orgasms. And then this third group, which is sort of these muscular or internal changes that women are experiencing.
Absolutely. So one thing, I think we can talk about the terminology to start. There's kind of a catch-all term that's used in medicine for this. It's the GSM, or genitourinary symptoms of menopause. And it's the overall changes of all those things you just talked about: pelvic floor, urinary tract, sexual implications, vaginal dryness, things like that. And then within that, we have what people call vaginal atrophy, and that used to be the term for everything. But we've kind of broadened that about, 10 years ago or something like that. So to start to incorporate everything. And so these changes that are happening. So as we lose our estrogen is really important for tissue function. So for our elasticity, for collagen production, for plumpness, for maintaining the moisture, for all of the blood flow, all of these things. And so as we lose that is reflected in what you're talking about as the actual physical changes. So you mentioned, color changes happening, and a woman might notice that if she's looking, but actually on exam, I'm looking for that. Her provider's looking for that, because even if she's not symptomatic, color changing might be one of the first things we see with that kind of shift in tissue and blood flow and things like that. And so we want to kind of get on top of it and address it before it translates to symptoms for someone.
Wow. I bet a lot of women don't know that either. Hey, you should be looking for this. Like, this is indicative of something else going on.
Most women, I think in the Sexy Sassy Sisterhood, it's a little bit different. We have some great participants,
Sure.
and people are really aware about their bodies. But I will say, in most of the clients that I come into contact with are not looking at their vulvas or their labia or tissues. And then we add to that like a thinning of the skin. So we lose kind of the plumpness. The tissue can get thinner, which means it's easier to tear. And so like even wiping with toilet paper might become uncomfortable, because we get little tears and the tissue becomes more fragile. And so then that might translate into more pain with intercourse, and then there's more dryness. And so women might be trying to use lubricant to make up for that, which is great in the moment, but it doesn't address the changes that we're having. So it's not like a long-term support. And then with that, we can also see changes to the urinary tract system, and so the actual tissues themselves. And so that can equate to increased risk of UTIs, but also when these changes are happening, the pH of our tissues the pH of the vagina actually increases, which also predisposes a woman for an increased risk of UTI. So women might notice that they're having chronic UTIs where they never did before, or they could also have a shift in the microbiome, so the bacteria that's kind of living in the vaginal area, and that can increase the incidence or the amount of time she's having bacterial vaginosis. So think what we would call BV. And all of a sudden she's having that chronically and can't get rid of it. Maybe she addresses it with medications, but then it comes back a month later. And it's because as the estrogen levels shift, the tissue changes make the environment more favorable for bacteria that wouldn't normally be there in large amounts, and our good bacteria becomes less. And we can talk about the true physiology behind that if we want to, but that's just kind of a general sign. And a lot of women don't realize that, this is what's happening. And when that's happening, it's almost imperative that we start thinking about vaginal estrogens so that we can avoid continued occurrence of this in the future. And for some women,
Right.
they're having that, before they even have any symptoms of dryness or what they consider dryness. Yeah, well, and that's just like at the tissue level. We can also see a shortening of the vaginal canal. We can see more vaginal stenosis. We lose some of that elasticity. That can be uncomfortable with any type of intercourse. The pelvic floor changes. A lot of women experience pelvic floor dysfunction in this time of life, which is more of the musculoskeletal component versus the tissue changes themselves.
Well, let's talk a little bit about that, right? Because I think that pelvic floor dysfunction it's simultaneously widely known and widely misunderstood, right? Because we think of pelvic floor dysfunction, and I think for a lot of women, they equate that with pregnancy and childbirth. Mm-hmm. And, then you've kind of got women who are thinking, well, I haven't had kids, so I didn't have any of that. Doesn't apply to me. Or you've got women who had kids, but, either they didn't experience pelvic floor dysfunction at the time, or they were, good girls and they did their Kegels and, they thought everything was fine. Let's talk a little bit about that, because I think that pelvic floor dysfunction we don't know about all the things that entails. I think, and I'm going to be really blunt here, but I think for a lot of women, it's sort of this myth that does exist, which is pelvic floor dysfunction is having like a loose vagina or peeing your pants, right? Mm-hmm. And it's sort of this catch-all term. And so we get told, do more Kegels. You'll tighten everything up. You'll be able to control your flow of pee, and that's it. You're good. Yeah. You're done. Yeah. So let's talk a little bit about that, because I think that it can be really frightening for women, right? They get into their late 40s and 50s and things start to feel weird, different. And this isn't pain like we're discussing with vaginal atrophy, right? This isn't that stabbing pain, that dryness, that itching, that tearing kind of pain. This is often a very different quality of pain for women when they're experiencing pelvic floor dysfunction.
Right. Exactly. And this is something, honestly, I screen for in all of my my patients, because I think a lot of women are walking through life with this without even realizing it, and it becomes more pronounced in our perimenopausal and menopausal years. So when we're thinking about pelvic floor dysfunction, the pelvic floor is a set of muscles. We can think of them as a basket, tiny little muscles with big jobs. Just like we can pull a muscle in our, let's say, low back, we can pull a muscle in the pelvic floor. And that's more likely to happen with things like childbirth, but it can also happen if we're lifting weights and not protecting our pelvic core correctly, or picking up a bag of groceries, or, something, really anything. We can see it happen with weight changes as well. And the pelvic floor's job is really to create stability, but also to hold kind of all of our organs up, more or less. So women with pelvic floor dysfunction might experience something like low back pain, hip pain, yes, urinary incontinence, so that urine leakage when they cough or sneeze or jump, maybe more frequency, but they might also have some of their, like the uterus itself, or the bladder, or even the rectum starting to fall a bit. And so that might present for somebody with a feeling of like heaviness, or sitting on a ball, or feeling something change. And so, like you mentioned, a lot of people are going to be like, oh, let's just do our Kegels. But for a lot of women, they're already, the dysfunction they're experiencing are actually tighter muscles. They haven't learned to relax those muscles. So if we do a Kegel, we're just going to make everything tighter. The other thing to think about is this is a collection of muscles. So if we think about it as a basket, and one muscle is tight and one muscle is not tight, let's say, there's a little bit of dysfunction between these guys. We can do Kegels and everything gets tighter, including the muscle that's already tight. So really what we need to do is to release that, address that dysfunction itself to help that person. And that's something that a pelvic floor therapist does. The way that something like that oftentimes presents itself too is with a deeper pain with intercourse. So women where we're thinking about, oh, it's more of the tissue issues, more of an estrogen issue, that might be pain at the opening of the vagina, that might get better with lubrication, versus somebody with pelvic floor dysfunction might have a deeper pain. If she changes position, it gets better, just something along those lines. That's how I tend to differentiate them when we're talking about pain with intercourse. And so this is really where the help of a pelvic floor therapist can be really beneficial before we just jump into Kegels, because in some cases, we're actually going to be doing more harm than good in doing that. And unfortunately, I still hear providers tell their patients, oh, just do Kegels, you'll be fine. But that's where we can push and request that referral to pelvic floor therapy, which is typically involves an internal exam to assess the muscles, and then maybe some different exercises, maybe biofeedback, breathing, just depends on what the therapist and what's been found.
Well, talk to me a little bit more, and for our listeners, about the role that aging has, right, on these internal muscle structures. Because, I think, we look and we're like, oh, I'm at the gym, like I'm losing muscle mass in my arms, right? Or, ooh, I'm not as fast as I used to be on the treadmill, I'm not lifting as heavy. Or, oh, it's harder for me to get out and do the things that I love to do. With the muscles in the pelvic floor, right, it's kind of different. We don't see those muscles. We don't use those muscles, I think, in the same capacity. And so maybe it's harder for women to understand how they're impacted by aging specifically.
Yeah. Well, we tend to lose muscle tone in general, whole body, as a function of aging. This is something we call sarcopenia. And so we're losing that tone of our muscles. And then our estrogen, our progesterone, our testosterone, those levels are shifting. And that impacts our tissues quite a bit. I mean, think about a woman, like a lot of women experience frozen shoulder. Frozen shoulder isn't, at this time of life, let's say, it's not an injury. That is a hormonal shift. We need the progesterone to relax the muscles. We need the estrogen to help build the connective tissue that holds our muscles in place and things. So blood flow shifts. There's so many changes happening that the muscles themselves are impacted. And then when we think about, I'm shifting away from pelvic floor for a minute, but the sphincters, the urinary sphincters are impacted. And that's where we can see because they're not properly closing potentially as we lose our estrogen, and that's where we can see this increased risk for UTIs as bacteria shifts. So we need adequate hormone levels to help maintain the health of our connective tissues, our soft tissues, our muscles, but at the same time we're losing muscle tone as muscle mass actually as a function of aging.
Okay. Well, for all of our ladies listening, if this is new information to you and you like it, please share our podcast. Let other women know. I think that this is such a hidden topic, kind of like we mentioned at the beginning. Women aren't comfortable sitting down with their friends and saying, hey, you know how we all sit and talk about the best products for the wrinkles around our eyes? How's everyone dealing with their aging vaginas, right? It's not something that comes up in the gym over brunch. We're not all sitting here talking about it. It's, we have our Ask Dr. Robins, we have our women in our private group who are saying things like, hey, I wish I could get a vaginaectomy because stuff is going so wrong down there. And I think that, this is a good way to share that information with your friends, with your loved ones, with people that have vaginas who might one day struggle with this. In fact, the likelihood is that they probably will experience some degree of this.
Absolutely.
And we just don't know about it. We're not educated about it, right?
Yeah. Well, and one of the things too, I would say there is, like, for so many women, they kind of just shove this away as normal. This is a normal part of life. It's a normal part of aging. It's normal by definition because so more women experience it than not. So that makes it normal. It does not mean we have to live with it. So if there is pain with intercourse, if there is increased UTIs, increased vaginosis, or even just discomfort in general, peeing when we sneeze, yes, it's normal, but it doesn't have to stay.
Right.
Yeah.
Exactly. Okay. Well, with that in mind, one of my favorite parts of our Modern Menopause podcast is me just giving Robyn increasingly challenging questions for her to answer from our listeners, from our customers, from, lovely ladies who might be listening to our podcast. So I'm going to kick off this question here to you, Dr. Robyn. I thought dryness was just dryness, but I've read that it actually progresses from dryness to itching to painful skin to tearing. Is this true? What does the full progression look like if it goes untreated?
Ooh, this is a great question and a little lesson all in one. Yes, if someone has the wherewithal to notice that, I think this listener is correct, where somebody might first notice dryness and then itching and then discomfort and then tearing, and that's also, that's textbook progression, right? So not everyone's going to experience that. And hopefully we're not waiting until there's so much change to the tissues that there is tearing and pain and, difficulty wearing pants and things. But some people, that's going to happen. So what's happening here is with the loss of estrogen, somebody's starting to notice the shifts. So as we start to lose estrogen, the tissue thins, we lose the squishy glycogen layer, we lose the moisture, we lose some of the blood flow. And so this can all start to be noticed depending on the severity of that shift and change. So not everybody who experiences dryness and itching is going to also experience painful skin or tearing, because maybe her body makes a little bit more estrogen, maybe she gets treatment and actually gets some estrogen from her doctor or something like that. So If left untreated, somebody that's experiencing this may, yes, absolutely have some discomfort, but could also be more likely to have more UTIs, more bacterial vaginosis, for the reasons we talked about before. So this is something, people will say, I don't need to treat it, I'm not sexually active, or, I'm not going to address it, I'm not sexually active. No. It's not just about comfort with intercourse, it's about true, total vaginal health for women. And addressing it is important for avoiding or for helping to avoid or decrease the risk of things like UTIs and vaginosis.
An important thing for women to consider, that vaginal health is just like any other. We keep our heart healthy, we keep our lungs healthy, we want to keep our eyes healthy, we want to keep our vaginas healthy for more than just sex. Okay, absolutely. Well, speaking of sex, though, we do have a question from someone who's written in about sex. So she says, I've been suffering with painful sex for years, and I've never once told my doctor. I'm honestly too embarrassed to bring it up. How do I even start that conversation, and what words do I use?
She's definitely not alone. I've done a lot of research on this topic, and most doctors don't bring it up, whether it's because they don't have the time or because they don't have the tools or the comfort themselves in doing it. So honestly, I think just being as simple and as straightforward as possible would be the way to go here. Just even going in and saying, hey, I'm having discomfort, I'm having pain with sex. This is new to me, or it's been going on for this long. What can I do about it? And even, when I'm having this conversation with someone, I will then start to differentiate between where's the pain. Is it better with lubricants? Is it better with changing positions? Does it only happen with penetration? Things like that. But her doctor might not be as comfortable. So maybe she even says something along the lines of, hey, I'm having discomfort or pain with intercourse. It's at the vaginal opening. I have heard that vaginal estrogen can help with that. Is that something that I'm a candidate for? And then she just did the whole thing for her doctor, and they can have that talk. Mm-hmm.
Right. And this is one of those things where I'm a therapist, and so it's different. I'm used to having those kind of uncomfortable conversations sort of all day, every day. But with this kind of thing, if it is something that she's really uncomfortable with, practice.
Love it.
Practice out loud, practice with yourself in front of your mirror, practice in your car when you're driving. Put it into ChatGPT or an AI and say, hey, how should I say this? Come up with a little script, practice using that script. Mm-hmm. The more comfortable you are saying it, the easier it's going to be to get those words out. It is definitely some little advice that I would give. If you're uncomfortable doing something, practice it, like I said, in the car, in front of the mirror, with people that you're comfortable with. The other thing I would mention here is, if she has a nurse that she's more comfortable with, who sees her prior to the doctor, mentioning it to them, and they might say to the doctor, hey, our client mentioned this and that kind of thing, because that's a tough position to be in.
Send it in through the EHR messaging system. Everybody has them now. If that's more comfortable than actually speaking it out loud, and then they know what she's coming in for at her visit. Mm-hmm.
Yeah, that's a good idea. Mm-hmm. Okay, this is an interesting one. We have a question from Della, who has written in. My primary care doctor has refused to prescribe hormones because I recently found out I have some calcium buildup in the main artery of my heart. I'm 74 and I'm already through menopause. I had HRT during the throes of the perimenopause years, but let it lapse for a few years now. I have constant vaginal pain and atrophy. What can I do to help?
Oh, this is an interesting question, and Della brings up a couple of great points here. One of the reasons that we don't tend to use estrogen with women more than 10 years post-menopause is because of some of the effects that it can have on the cardiovascular system, unfavorable effects. Now, that being said, that is for systemic estrogen. We're talking estrogen pill, maybe the patches, probably not, but whatever, systemic whole body estrogen. That's not for vaginal atrophy or for vaginal pain. When we're treating as doctors, when we're addressing vaginal symptoms, that's not a systemic or a whole body estrogen, and those same effects or those same concerns don't apply. It's thought that the estrogen stays very local to the area for the most part, but we don't seem to have the same risks for the cardiovascular system when we're using it just vaginally. So in this case, this is her primary care doc. I would probably have that conversation if she still has a gynecologist, maybe switch who she's talking to, because her gynecologist is going to be more experienced with writing those prescriptions and likely knows that, it's not going to increase the concerns, assuming there's nothing else in her history. But really, there's no contraindications that I can think of at all. Almost none. There are a few, of course, any vaginal cancers, active treatment, things like that, where we wouldn't use vaginal estrogen. But when we're thinking about something like this, it's not considered an issue.
Okay, this is a tough question that we've been sent in. I haven't been able to have sex without excruciating pain since 2007. My doctor told me I have no blood flow and paper-thin walls, but offered no help. Is it actually too late to reverse this, or can tissue really be rebuilt even after years of atrophy?
Poor thing. 2007 is a long time. We're talking like 19, almost 2 decades. I don't want to say yes, and I wouldn't say no here. This is something where, depending on what's going on, if it's truly just atrophy and there's no other conditions that are present, some women have something we call lichen sclerosis or something like that. It's possible it could help, but with something like this, it likely will take longer than a woman who's, say, 45 and just starting to experience symptoms and brings some support in. So with something like this, this is something where she could certainly, I would think, have the discussion with another provider or something and start considering vaginal estrogen to support that. So it helps to plump the tissues and increase blood flow and things like that. But after 2 decades, the amount of relief may be less, maybe not, but it would certainly likely take a lot longer for somebody experiencing something like this who didn't intervene sooner than somebody who's only been experiencing it, say, for 2 months. We're so used to, as a society, like taking our pill, like we're sick, we take our antibiotic, we feel better in 24 hours.
Right.
Hormones don't work that way, whether we're talking, vaginal estrogen or whole body. And we can do that on another day, but it's a really good example of that.
We are conditioned. It's like when you ever have to take steroids and they don't work that fast. And by not that fast, I think it takes like 2 days for them to kick in. I've had to do it a couple times and I'm always enraged. I'm like, why am I not better? It's been 12 hours. Why isn't I not fixed? Okay, we've got time for one more question. And so then we'll wrap things up. Where is the best place to apply?
Applying it, most women will apply to the inner labia, but some people are really sensitive, and so they prefer to do to the inner leg crease. And so really I would think about the best way. She asked what's the best place to apply. I think the best place to apply is the place where it's best most tolerated. And so if anybody's concerned about sensitivity or something, doing a patch test on tissues that are like the leg creases versus the labia first.
Yeah. And we always say to women, inner and outer labia is great. If you can't apply it there, apply it on the crease of your thigh, which is probably why she's heard these things. We can say the typical thing that we say is just don't apply it near the urethral opening. And then with the perineum, a lot of women do want to apply it there because that's obviously where they're experiencing pain and discomfort.
Sure.
Totally fine to do that. You obviously just want to be careful. The closer you get to the perineum, the closer you obviously get to the anus. The closer you get to anus, the closer the risk of bacteria transfer. If you're applying it elsewhere, I believe Kate back in the day, and this was like my favorite instructions, this was like way back, was like, put on your silky peach cream, apply it, and then just like walk around naked or just like hang out with your undercarriage open. But it is actually good advice because it stops like contact. If you're wearing like a pad or underwear, the cream's going to get on that and then it's going to move around, which can obviously increase the chance that bacteria moves around and whatnot. But yeah, like he said, Dr. Robyn, wherever you can apply it consistently, where there's not discomfort or pain is sort of the good place to apply it. Awesome. Well, I'm glad we were able to talk so much about vaginal aging.
Yes.
I'm sticking with it. I'm sticking with that as my theme for today. And thank you for everyone who is listening. If you enjoyed this episode, be sure to subscribe and stay tuned for our next episodes. We have some great ones coming up. We do also have a form you can click on if you click on the information about this podcast, and you can submit any questions of your own for the wonderful Dr. Robyn. See if you can stump her. It's not happened yet. But we always want to hear from you, and you might have a chance to be featured on the Modern Menopause podcast. But that is all we have time for today.